Okay, so I'm just gonna let people enter the room if it's okay with you.
Okay, no problems.
Perfect. Bonjour tout le monde, bon midi. On va peut-être laisser quelques minutes avant de laisser les gens rentrer dans le Zoom. On devrait commencer peut-être dans 4 minutes, là, donc je vais laisser les gens arriver un peu. Bien entendu, le webinaire va être enregistré et puis ça, on va pouvoir vous partager le webinaire aussi si jamais vous voulez le réécouter. Donc, on va commencer le webinaire. Donc, bonjour à tous et à toutes. Je m'appelle Monica, je vais m'occuper du webinaire aujourd'hui. Donc, avant de commencer, comme vous le savez, là, le webinaire est en anglais pour le premier. du webinaire de l'année 2024, mais bien entendu, là, les autres webinaires vont être en français. Et je vais switcher, dans le fond, là, en anglais là, dans quelques instants. Donc, pour le déroulement de la présentation, justement, là, on va débuter dans quelques instants avec la conférence de Ben Cormack. Ça va être suivi d'une période de questions et par la suite, la présentation devrait terminer là, vers 1 heure. Quelques consignes pour le webinaire. Donc, bien entendu, tout le monde, ça a été réalisé. Là, donc, laissez votre micro fermé, votre caméra fermée durant les présentations. N'hésitez pas là, à utiliser le chat pour poser vos questions ou sinon, vous pouvez aussi là, lever très bien la main puis je vais pouvoir vous donner la parole pour la période des questions. Et justement, là, je vais pouvoir vous donner, c'est ça, le droit de parole. Donc, on va commencer avec la présentation de notre conférencier, Ben Cormack. Ben Cormack owns and runs Core Kinetic. It is a musculoskeletal therapist with a clinical background qualification in sports therapy, rehabilitation, and exercise, stretching back over 15 years with a special interest in pain and its relation to movement. Ben is a popular international presenter who has delivered conferences, presentations, and courses all over the world. Ben specialized in movement, exercise-based approach with a strong education component and patient-centered focus. So we are very happy to welcome him for our first webinar for 2024. It is also an international speaker, so we are very happy to have him. So I will let you go, Ben, you can share your screen.
Great. Well, thank you very much for having me. It's my pleasure to come and have a chat with you. So I do apologize. I'm going to have to do it in English. I'm very much unilingual. Being an Englishman, we're not very good at languages apart from English. So I'm just going to go with what I know. It would be ugly otherwise. So yeah, thank you very much for inviting me. So I'll just tell you about some of my conflicts of interest. I do run educational courses, and I have a couple of companies that run educational stuff to do with pain and exercise and movement and how they work and how we might use those therapeutically. Our objectives today are going to be to maybe understand modern pain science a little bit better, or even a little bit more succinctly, understand a little bit about the evidence around exercise and pain, which I think is really important, and then think about how we can get the dosing for exercise and pain to kind of work together for the patients that we work with, because I think that's an area that can be challenging to get people moving and what they experience and what they feel. So yeah, I was trying to be a bit contextual. So this is my presentation for the Quebec Pain Society. Let's start off by talking a little bit about pain. And I think pain is quite a misunderstood subject. I think our societal perspectives of pain don't always reflect, some of the advances that in our understanding around pain over the last 20, 25, I mean, you could say longer, if we go all the way back. So maybe 50, 40, 50 years. So for me, I like to simplify how we understand pain, because I think it's much easier not only for clinicians to understand, but then also for patients potentially to understand as well. So I think when it comes to movement and exercise, there's one really, really big fundamental message that I kind of want to get across to people, and that's simply that the feelings or the pain that we experience doesn't always reflect the state of our tissues. And I think that's a real key fundamental message. So put it a little bit more poetically, hurt doesn't necessarily equal harm. And that's important because I think when people use their bodies when they have pain, whether that's acute or chronic, it can often be uncomfortable. It can often be painful. And the question I always get asked is, Ben, am I making it worse? So if I'm moving and it hurts, am I making this worse? And I think that's one of those things that often turns people away from movement and exercise and activity when they have painful problems. I think from a societal perspective, it's very much perceived that, you know, what we feel is reflective of the state of our bodies, right? And to some degree, without understanding a lot of the complexity of pain, that makes some sense. But that's one of the keys, you know, to pain science, is just to start to understand that there are lots of ways that what we experience and what we feel is not simply reflective of our bodies and the state of our tissues. And for some people, that can be an extremely empowering message. However, sometimes the message is not enough. We actually need experiences, movement experiences, or what I like to call movement proof, to kind of help build that message. And sometimes we dress pain science up in a little bit of complexity. And because of that, I think sometimes the fundamental messages can get lost. All right. We don't always need to know about the nerves and the receptors and these type of things. Sometimes it's the bigger picture messages that are most helpful. From a clinical perspective, I think it's really important for clinicians to understand why hurt might not equal harm. And that is really important that we understand some of that science, although we don't always need to relay that science to patients in a very technical way. All right, that would be my opinion. So we know that we have changes at peripheral receptors that might change how nociceptors activate and change the action potential and change the signaling that comes from the periphery. We have changes that happen at the, more centrally, the dorsal horn, places like that. Again, where we get lots more transfer of information between the two sides, lots more channels open up and lots of chemical exchanges happen. And again, that kind of modulates or augments the signal. And again, we can feel a lot more pain or have a lot more nociception that, sometimes goes into having pain than maybe we would with unaltered nociception. We have something that I find fascinating, especially when it comes to exercise, which is the neuroimmune system, how cytokines and macrophages and, all these other fantastic chemicals work. We have changes within what happens temporarily with descending inhibition and opioids and cannabinoids and all these wonderful endogenous chemicals that we have floating around, as David Butler calls it, the drug cabinet in the brain. We have changes that can happen in terms of the cortex and its plasticity. That was a really important line of research of people like Herteflor and Lorimer maybe 10 or 15 years ago, and that seems to have run out of a little bit of steam for whatever reason. Maybe it's too expensive to stick people in fMRI, etc. We don't know. We know that we have a psychological aspect or a cognitive aspect. We know that we may have, things like associative learning, getting into some kind of, interesting memory, things like neurotags, etc. And, some of these kind of interesting work, again, by people like Lorimer and Johan Vlaen, etc. And then finally, maybe also the stress systems that we have and HPA axis. What this tells us from a clinician perspective is what happens at the tissue isn't always reflective of what we feel. All of these biological processes or psychological biological processes or neurophysiological or neuroimmune stuff is happening, and it changes what we experience and what we feel. And so fundamentally, the message is that hurt doesn't equal harm. And from a clinical perspective, it's good to know the science. I think from a communication with patients perspective, it's good to try and boil those messages down into something that's simple, understandable, and we can put it into action. All right. And we also have to understand as well what may cause pain may not be what maintains it. And we may have three areas to causation. One would be what predisposes us or risk factors. We have initiating or trigger events. And then we also have some maintaining events as well, or maintaining factors. So again, people are often very concerned about, you know, these parts of their body or movements or actions that can trigger pain. And we often sometimes see those as causes. And that can kind of maybe turn people away a little bit from getting their bodies moving and using their bodies for fear that they're going to, you know, again, create more damage or these type of things. And we have to realize that I think pain, an analogy that I use for this here is Russian dolls. And that's simply because we may have a triggering event or a painful situation or a painful tissue. And, you know, we have to understand that the experience of pain is not just the sensation of pain. And people have a painful sensation or a painful movement or a painful body part, and they go and we go to the physio and they tell us that, you know, we're broken, we're damaged, we shouldn't do this and we shouldn't do that. And then, you know, people worry and they create another kind of layer or another doll to the problem, to the painful experience. We may get an image, and that image suddenly shows something that may be related to pain, or it may not be related to pain. And again, that adds another layer to the problem. And actually, the experience of what someone has is a culmination of their beliefs and their feelings and their what they've been through and their process through the medical system, etc. So it's not just the sensation, it's not just what we feel, it's not just how we feel, but it's the whole experience together that's really interesting around pain. And all of those things ultimately shape our behavior. And that's the really important thing. And those behaviors can be to avoid using our body. Those behaviors can be to see certain things as injurious or damaging. And often it can promote a little bit of a message of, not of engaging in sometimes the health, the lifestyle, or the valued activities that people want to do. Okay. So there's a whole bundle of different facts, and I'm trying to do something that I might give a 3-hour lecture on in about 3 minutes. So it's certainly not going to be comprehensive, but certainly trying to touch on some of the concepts and the ideas that I think can be helpful within this context. And just to help us understand some of that behavioral aspect of pain, we certainly have the sensory bit, what we feel. We have the emotional bit, how we feel. And then we also maybe have the cognitive bit or the behavioral bit, whereby, and this is a paper that came out back in 2017 that really, you know, was a seminal paper for me, certainly. And it's looking at not what causes pain, not what we feel, but how we interpret the problem. And that's one of the keys, is that interpretation drives our behaviors and how we do things like use our body. And as we can see, you know, this is a simplistic model, but we see that up in there in the green, we have this kind of positive interpretation of my painful experience. I understand it. It's controllable, meaning that, you know, maybe I have some self-efficacy around it, meaning that maybe I have an internal locus of control. Maybe it's time limited. You know, I know it's going to be episodic and it's going to go away. Maybe I don't view it as dangerous to my existence or to my future. Now, there may be another way to interpret that problem. The problem is still the same, but maybe we interpret it in a less favorable way. So we have a lack of meaning. We don't understand it. It's uncontrollable. Maybe it pops up at strange times and it feels different at different times, and it moves around and it shrinks and it gets bigger, and it feels one way one day and maybe one day another. Maybe we see it as chronic. And we know that patients interpret chronic not just as chronos or time, we know that they may interpret it as being worse or here forever or it's never going to change, which is the opposite of being time limited, isn't it? It's now suddenly we see it as being here forever. How does that affect our behaviors? And we have, you know, two outcomes here. One might be, I'm going to return to normal. I can handle this pain. I've had it before. I'm going to respect it, but I'm okay. And then maybe we have an element of suffering that goes on for longer than we would like. And that I like the way that we view it, not just as the cause, but also the interpretation and the effect on our behavior moving forward. And I think for me, the behavioral aspect of pain is the most important because it affects what we do and how we use our body and the things that we engage in. All right. So this is kind of my perspective of pain. And this was a really fascinating paper for me, actually. Really, again, another one that really enlightened me. And this is from Natalia Costa, who's a Brazilian working in Australia. And they looked at the concept of a back pain flare. So when people have flare-ups, what are some of the features that exist around this flare-up? And what they found actually was that people with a pain flare-up don't always have more pain. That they don't actually, they may not say on a VAS it's a 7 instead of a 5. What they did find though, that sometimes it might not be to do with pain increasing, but it might be to do with our ability to cope with pain decreasing, which helps explain, you know, all these other factors that we see floating around when it comes to pain from, you know, these psychosocial features that may not always, I don't know if we can say they always cause pain. You know, that's still an interesting link. Certainly, are they affecting pain or decreasing our ability to cope with it as well? And I think, again, that's something that's super important. So a little model that I think is really nice is from my good friend Peter Stilwell, who is he is a Canadian, actually. I think he's in Halifax. And I think he does some work at McGill. And so he's got a 5 E's inactive model, which I think is really a nice way to start to look at pain. Thinking about pain being embodied, you know, not kind of mental, just neural, as sometimes we talk about the brain a lot. Well, actually, you can't really have pain without the body. It's embedded. It has a social element to it. In the fact that it disrupts our social world, it disrupts family life, it disrupts work life. It's inactive, so it has a movement part to it. You know, it hurts when I lift my arm, or it hurts when I bend over, or it hurts when I, you know, play tennis. It's emotive, that it has emotions associated with it, whether it's frustration, whether it's despair, you know, the whole gamut of emotions that we see, and it's extended. It doesn't just affect me, it affects my family, it affects my friends, it affects society. So I really like that as a model to move just beyond kind of pain in the brain to something that's a little bit more comprehensive, if you like, and that's what we would describe as an inactive model. And me and Peter, we went on and wrote a very philosophical paper. Probably too much philosophy in there. It wasn't an easy write or an easy read, and it took a long time to get through peer review. But if you're ever interested in kind of looking at inactivism and its relationship to pain and its relationship to things like the biopsychosocial model, please give it a read. If anyone wants it, I can send it to them. It's not open access, I do apologise. But, you know, that's the world of publishing. So that might be an interesting read to get across a little bit more about our thoughts about pain and biopsychosocialism and inactivism and these other, you know, concepts that people talk about. But I think really I want to boil this down into some really simple, practical rehab messages that I like to give all of my patients. And what hopefully that does is primes them, or it helps them, you know, get moving, get involved in things that they enjoy, and get back to valued living. And I think that's the most important thing, all right? So pain does not mean you are broken. I think that's a real key message for people to hear. Because I think that's how many people feel when they have long-term persisting pain. Hurt doesn't equal harm, which overridingly I think is one of the key messages of pain science. pain can change. That there are people out there that have changed their long-term persisting pain. Maybe it's through ways that we don't consider. Maybe it's through getting back to life sometimes that has a big change in people's pain. Pain is always real. You can't see pain on a scan, but it doesn't mean it's not real. And I think many people have been kind of let down because all their tests are negative, and we can't appreciate where the pain comes from, because maybe sometimes we have a narrow biomedical perspective of what causes pain, what maintains it, what affects it, etc. And then we don't always need to know what is wrong to help. We can have a very salutogenic perspective whereby we know there are positive things that humans do that help life. And can we engage in some of those and sometimes move the needle without having to pinpoint a tissue or pinpoint a condition, etc. So you can live life even with some pain. I think that's a real key message for many. We don't have to find the perfect method to help. There might be many things that could help, and there might be many roads to Rome. We just need to find the one that's right for you. Often it's a bit of trial and error to get it right. We don't always hit the nail on the head the first time. The journey will often have ups and downs. And finally, sometimes the issue is more than just the tissue. All right. So there's some really basic, simplistic pain messages that I think are about moving forward. And I think if we can get people moving forward, that's often a more optimistic, beneficial place that we can start. So often people are told what not to do, so often people are told the negative side of things. How can we have positive rehabilitation messages? And thinking about that model, what is that model that we can look at that is a positive model across people? And it's not just about pain. Could we talk about anxiety? Could we talk about depression? Could we talk about mortality? Could we talk about health? All of these things may be about dysregulation of our lives, or our functioning, or our physiology. Are there positive things that are important for humans? So thought behaviors, so self-efficacy, whether that's for exercise, whether it's for pain, having an element of resilience and an ability to bounce back when we're kind of pushed over, which often happens in a pain rehab journey. Positive behaviors that exist within exercise, that exist within health, that exist within our lifestyles, and positive behaviors where we do things that we value and we enjoy. Sometimes we do things because we think they're going to get rid of pain, or we do things because we think we have to. We need to do things that bring us joy and we value. And I think that's a powerful perspective. And then finally, the forgotten part of pain rehabilitation is the social aspect. And I would say one of the most important things that I point people in the direction of is movement and exercise opportunities or affordances that involve a social aspect. So we know that lacking purpose is not good for human beings. Man's Search for Meaning was a great book, if anyone's ever read that, by Viktor Frankl. And being connected. And so many people that I meet who've had long-term pain, they lose connections in their lives. And sometimes it's about refinding some of that social element, not just what's the perfect exercise, or should I activate my core for my back pain? Maybe sometimes we needed something a little bit more that gets us using our bodies, gets us doing things that we enjoy, but gets us connected with other people as well. I think that's very, very powerful. So what are my treatment principles? What do I think are important? So for me, as I've talked about, the real key to rehabilitation is doing the things that we love to do. So I don't care if people exercise or not. That's on you, right? That's your vibe. But I think that the key to rehabilitation is about our lives and our enjoyment. And I wouldn't want someone to swap doing something they enjoy for going to the gym, for example. What would be the point in that? So for me, the real power is getting, finding out, what does this person enjoy? What does this person value? What do they need to do? And helping them get back there. I think that often involves a cognitive element, helping people understand their problem and make sense of their problem often helps them move the needle a little bit. Helping understand people's beliefs and helping sometimes restructure them or sometimes accept them. And then also about changing our behaviors, both thought behaviors and maybe our physical behaviors as well. Again, not seeing them as separate. And then finally, I think these things are important, that it does need to be embodied. It does need to be, not just cognitive, not just physical, but bringing the two together. And I talk a lot about movement proof. We can tell people it's okay to use their bodies, but until they experience that, often we don't update the cognitive side of things. And I think that's where we need to borrow from the world of things like exposure therapies. But maybe it's not always perfectly related to pain, but certainly there are some exposure principles that might be important. But bringing together these three aspects for me, I think it is these are the most important aspects. But in this wonderful world of varying opinions, in this varied tapestry, in this smorgasbord of ideas, certainly we have to think about what are our own treatment principles or our own valued ideas. These are mine, and this is where the framework that I like to work within. And I love the quote from Louis Gifford, very, very famous English physio, or famous to me anyway, looking at the idea of thoughtless, fearless movement. And sometimes that's what I don't like about exercise for pain, is sometimes we're thinking about, am I doing it right? Is my body position or my posture perfect? Am I going to get hurt? And the most amazing thing is when people do things and get back to just bending over, or get back to just going to the gym, or get back to playing tennis, or get back to playing with the grandchildren, or going gardening. And they don't have to think about it anymore. They don't have to have apprehension. They don't have to have worry. They don't need to do it cautiously. So I love that terminology, thoughtless, fearless movement. And we wrote another paper. This time I didn't write it with a Canadian. I wrote it with an Italian. And this with my friend Giacomo Rossatini, who does lots of placebo and nocebo research. This one was released, I think. Released, is that the right term? Published. It's not a record. It was published in November 23. Just looking at some of the other aspects that maybe go around exercise. We often focus on the kind of the sets and the reps. And we conceptualize this as a donut. But just looking at some of the things that form the whole of the donut, the WH, not the whole of the donut, the HOLE, and just thinking about these aspects from, good listening to accountability to making sure people have the right instructions, have a positive experience. We set people up for success. We help build self-efficacy, etc. And if again, this is open access, so that costs me money. But there you go, that's life. And that's another paper that we wrote and put out that is less philosophical, which is good. Sometimes you need to do the philosophical stuff, and then sometimes you just need to write stuff and get your message across, right? One of the things that we do need to appreciate, and this is just thinking maybe a little bit more from an applicability standpoint or a implementation standpoint, is that we shouldn't confuse exercise for fitness as being the same as exercise for pain. If we work a muscle, for example, and we give a muscle a good dosage of exercise, hopefully it grows, it gets bigger, it hypertrophies. And the more we go to the gym and the more we load it within reason, the more it's likely to grow, right? That's the way that it is. But if you think about pain is a kind of a system, if you like. And I apologize if I've paraphrased that badly. I know there are some philosophical pain nerds out there who might get upset with me. But I've battled that battle before. If we work the pain system, it doesn't get, I don't know if it gets bigger and stronger well, it does get bigger and stronger, but the effects are a net negative, not a net positive. Okay, so maybe sometimes with movement and exercise and activity for pain, less is actually more. Sometimes we're not looking for the biggest dose, because the biggest dose might cause the biggest reaction. Basically pain is a kind of a sensory system, isn't it? It senses stuff and it reacts. And if you stimulate it with a big dosage of something, it's likely to give you a bigger reaction. And sometimes I think that's the kind of the misinterpretation of bringing these two concepts together. And there are three things that I tend to consider when I work with painful problems and movement and exercise. One would be the sensitivity of the system. So that might be the severity and the irritability. Going back, you can tell I'm an old guy. We're talking about Maitland stuff from way back in the 90s or even before. You know, that idea of severity and irritability that make up that kind of sensitivity aspect. Many painful problems, you know, that's the key, right? We would like to know about this person's physical capacity. How much are they able to move, and are we going beyond their physical capacity? But then another terminology I think is important is the element of psychological flexibility. And I would probably call that cognitive flexibility if you pushed me, because I think psychological flexibility in the ACT world has a slightly different meaning. And we don't want to get too much into, you know, it being pathopsychology. I think it's very much cognitive appraisal, actually. So three concepts that I think are really important to kind of blend together, which would be our sensitivity, or what we feel, and the irritability of that would be our capacity to actually do the work, the movement or the activity or the exercise. And then finally, how able we are to change or maintain a behavior that might be positive for or negative for what we're trying to do. So those three concepts together. But one of the issues that we have is that we don't really know exactly how exercise affects pain or movement or activity. We have research in lots and lots of different areas. So could it be the inflammatory system? You know, that might be what happens in terms of, you know, the cytokines and the macrophages and all these other things that you don't talk about on a first date because they're way too complex. We have self-efficacy. We know that self-efficacy seems to be quite a good prognostic factor for recovery from most musculoskeletal pain. So that's our pain self-efficacy. So our ability to do things with pain. And I do wonder the desire often in rehab to take pain away. Sometimes do we need to appraise it differently? Sometimes do we need to understand and make sense of it differently? Because if we always take it away, are we changing pain self-efficacy, or are we maintaining the pain self-efficacy? And that may not be a positive. Could it be biomechanical? The evidence would suggest less so, but there still may be an element. Could it be belief-based? Certainly beliefs affect behaviors. Could it be biomotor? So strength, range, all of these traditional exercise variables that don't seem to have a brilliant relationship with pain. Could it be basic physiology? You know, just getting things, good stuff in and bad stuff out. And we know movement can provide that process. We know in osteoarthritis, for example, movement is vital for local physiology because we don't always have the neural or the mechanical pump, if you like, from blood flow, etc., to make that happen. Could it be descending inhibition, those opioids, those cannabinoids, those serotonin systems, those you know, things that inhibit and things that excite your GABAs and your NMDAs and those type of things. NMDA, not MDMA. And then finally, our expectations as well. How do they, you know, how do they play into it? And this is really fascinating as we look at new mechanistic-based research. So just starting to understand a little bit more about some of the mediating factors and the mechanisms. Remember, mediation is causal variables, really, isn't it? It's what has created change between two variables. So exercise and pain, what may be a mediating variable may be pain self-efficacy or pain catastrophizing changes. We have lots of things that modulate pain or create temporary changes in sensation, but they may not actually mediate, explain the causal relationship between two things. Recent paper from my friend Leanne and another friend of mine, Geronimo, they looked at this with Pilates, and Pilates traditionally would be, oh, it activates your core, you know, it makes us strong, etc. And they looked at all these different variables, and they actually found out what mediated pain intensity changes and physical function changes was actually changes in kinesiophobia, so fear of movement, which is fascinating. So it's not a physical variable, it's very much a psychological variable that was seen as the mediating factor. And here we see a little a little diagram there looking at how we see the variables working. This was another paper that came out last year from an Australian group. We have Laura Mosley, James Macaulay, who was an Irishman that lives in Australia, Aidan Cashin, and they looked at an education and graded sensory motor retraining. So both a cognitive and an embodied approach. And what they looked at there was what were the mechanisms of the change within this. And here we see actually these traditional sensory motor variables or motor control based variables such as tactile acuity or motor coordination didn't explain a lot of the results. Kinesiophobia, pain self-efficacy, pain catastrophizing, our beliefs in our back actually mediated a lot of the effects. So we could say the education side was most important, but maybe it needed the movement side, but not changes within the physical movement apparatus, again, which is fascinating. So if we have these cognitive elements, if we have these embodied physical movement experiences, if we can do that around things that we cherish, we love, we enjoy, hopefully we can get a bit closer, I think, to helping people. And I think we're seeing that with things like cognitive functional therapy, and very much integrated approaches that are looking at education, lifestyle, what's happening in terms of movement experiences, etc. So I think gone are the days of exercise and manual therapy and, you know, dry needling as these standalone type of things. I think we need very much to understand why we hurt. We need very much to you see how that relates to our behaviors. We very much need to have experiences that may update or may challenge or may restructure some of those behaviors as well. But fundamentally, we're at a position where we don't know everything and we haven't explained everything quite yet. It's all a little bit messy, if we're being honest. And research sometimes just makes it messier. But we need that research because it does also enlighten us as well. Really importantly, this was some work by Catherine Sluka, who looks at a lot of kind of immune system, you know, or systemic effects of exercise, both animal models and human models. And really importantly, what they found was that sedentary behavior was actually related to what we might see as pro-nociceptive systemic priming. So we see that things like NMDA receptors, which are excitatory, as I remember, are working. They're facilitating some of the nociceptive apparatus. If we are more physically active with a decent level of vigorous activity, we see actually some of the opioid systems turn on and start to, you know, chuck stuff down the descending tracts and, you know, start to dampen down some of that nociception. And we also know that neuroimmune work, so great work by people like Jo Nays, people like Andreas Polly from Brussels, they're also working on, you know, exercise's effect on the immune system. The thing is, we don't have sets and reps for that. It's much more behavioral. It's about engaging in, say, 4 to 6 weeks of exercise. And some of the work into epigenetics is fascinating because we know that our behaviors have an effect on gene expression. And it's not just about giving someone an exercise. Sometimes it might be about changing some of these behaviors to facilitate some of these internal mechanisms, whether they create epigenetic change, whether they, you know, neuroimmune, whether it's descending in, we don't know. But certainly we need to engage in it behaviorally to get these effects. These mechanisms don't train themselves. And one of the most frustrating things that I find around exercise and pain is this idea that people want to know what's the best exercise for back pain. And we went down that road many years ago with the core stability approach and activating the TVA. And for some people it helped. For some people, it didn't. And maybe it helped people, but not for the reasons that we thought it did. You know, we had great work from people like Anne Mannion, who kind of looked at core activation and found, well, you can activate your core differently, but you still got pain, or your core activates the same, but you don't. And so maybe that's not always the key. But can a core stability exercise help someone? Well, sometimes it might just be moving. All right. and that's great, and that's brilliant. And that basic behavioral change might be fundamental. So what is the best type of exercise for pain? Well, there's the $1 million question. And if anyone wants to send me an email after the lecture and pay me that $1 million, I will gladly tell you the best exercise for pain. That's absolutely fine. I take Bitcoin mostly, and we need to do it away from any kind of tax problems, okay? But I've definitely got the answer. Of course, that is a joke, before anyone truly believes me. But here is a Cochrane review looking at exercise for chronic pain. And what they did was they looked at a whole bunch of different stuff that could help people. And we see aerobic and strength and flexibility and range of movement. All of these things could be beneficial, but they could also not be beneficial. And there's your problem, that there's this lots of potentially positive stuff, lots of potentially negative stuff, but without a patient, sometimes we never know. And that's why we need to listen, we need to care, we need to engage, because we need to find out more about this person. And that fundamentally is the essence of the BPS model. And I think that relates to finding the right solution for the person in front of us. And research doesn't always help us with that. We see exercise for tendinopathy, genius suggestions: avoid rest, use active treatments, use calf exercises. That's great, isn't it? Don't use bicep curls for Achilles tendinopathy. That's good information. But again, some exercise is important, but we don't always know exactly what, how, when, and for who. And again, first line for chronic lower back pain, we see that exercise therapy is good, brilliant. Again, the question is how much, when, what, all of these different things. So it's a very, very broad brushstroke when we talk about exercise and pain. And of course, we see there that, you know, actually, when we have acute back pain, there may not be any first line treatment. We see that advice to remain active. We see that education seem to be the first line treatment, because not very much is shown to be that effective for acute back pain. But I could talk about the whole kind of misnomer of acute and chronic back pain for hours. We know it's an episodic problem, and there's some great work by people like Alice Kongstead. And anyway, we're going off the beaten track. But really a key message is we can't always be guided by the data. Data and research gives us ideas about what might help this person or what might not help this person. But ultimately, I think a psychosocial perspective says, who is this person? What is their life? What are their previous experiences? What are their beliefs and emotions? How do we find the right answer for them? Because there isn't one for everybody. And here's some great example of that. If we look at a common exercise type tendinopathy, we see that when we give people a very, very similar dose of exercise or the same dose, we actually see that they often have different responses. And I was rereading a paper today from the great Kelly Norgall, and she wrote many, many years ago about the hypoalgesic effects of exercise. And brilliantly in there, it talked about people's responses, especially when they have chronic problems, are very, very varied and individual. And that's exactly what we see with this isometric research, that we see when we give people the same dose or the same amount, actually based on their personal baseline, based on maybe their irritability that we don't measure, based on all these other factors, they have different outcomes. And that's not just this one piece of research. We see this across the board, actually, when we actually look at individual outcomes. So this isn't responder data, that's something completely different, but it is individual outcomes. I don't want to say responses, because we know responses could be wrapped up in placebo and these type of things. So it's hard to say it's actually a response to treatment, but it is an outcome from treatment. All right, I'm just being philosophically correct. But again, what do we see here? To the same dosage of exercise and different exercises from isometric to isotonic to walking, we see a really, really varied set of responses. So does research reflect my patient? No. Can I use research to help with my patient and work with probability in a Bayesian perspective? I think you can, just understanding that as a process. One of my favorite papers, and I don't know if everyone else has a favorite paper, maybe it's just me. This came out a couple of years ago, and it looked at patellofemoral pain. And what they actually did here was very much a cognitive and a behavioural approach. And it's based on work from a guy called Aj Indal, who was a Norwegian, and he looked at lower back pain back in the 90s, and that was when I was a student. And what they did is they looked at a whole different three different types of exercise. Well, they looked at knee exercise for knee pain, hip exercise for knee pain, and then finally what they described as free activity, which is kind of go off and do what you want. But they gave all three groups the same education. They conceptualized the problem as not an injury. In the same way they, may conceptualize non-specific lower back pain as not an injury, because we don't know what the pathology is, or we can't say exactly what that pathology is. So they gave a cognitive appraisal of what the problem is, de-threatened it, and then they also gave pain monitoring advice, which was increase your physical activity, but don't provoke the problem. It wasn't don't have no pain or any pain. That was my bad English. I don't speak English, by the way. I speak London, which is its own individual dialect. So there was pain monitoring advice. There was conceptualization of the problem, and actually it didn't matter what the type of activity was. And this for me is a really interesting approach to what we're looking at. So if we just go into the last couple of slides, and I probably have way too many slides, so I do apologize. Talk a little bit about exercise dosing. Is I would like to know, is my patient more likely to sensitize to a stimulus that I give them, or habituate to a stimulus that I give them? Or can I give them a stimulus and maybe there's no change, and that's positive because we haven't reduced pain, but maybe we've introduced and done more activity. And that can be an important movement in another place. So on the left-hand side, we have some of the risk factors that I think switch us to a little bit more of a sensitization. That could be multiple mechanisms. And then on the other side, maybe we have elements that switch us a little bit more towards a habituation or an ability to tolerate stimulus. So we're a little bit more robust. And these may be factors that work positively for us. Again, what we're trying to work out, where does my patient sit on that spectrum? But ultimately, now I'm going to quote myself because I've always wanted to do this. Listen to your patient, they're telling you the exercise dosage. Ultimately, we can get ideas from research, right? We can get probabilities, inferences from research. But where does the true information come from? From our patient. Is that the direct effect of an exercise? We don't know. But it's the only report that we have to work with. All right. So simply being, we need to find an appropriate load. And that could be lots of different types of thing. But one of the things that we don't do very well is as people become less sensitized or less sensitive, we don't always take advantage of that. Sometimes we can play it a little bit safe, and maybe we don't always get the adaptations that we want. And, sometimes we need to push on through, and that can be very helpful. And within what we do practically, and again, this is what I teach a lot about, is how do we actually find some movements, or how do we find some things that we use? I call them movement snacks at the very sensitive end of a painful problem. And maybe within this continuum, we have to have certain ways of working, or certain ways of managing dosage that may affect that sensitization or habituation process. Finally, last slide, really simple way that I work, looking at two subjective measures. One would be VAS. Of course, we describe it as objective. It's anything but objective. and also RPE, our rating of perceived exertion. So can we use exertion as a proxy for effort? Absolutely, we know that. Can we use that as a proxy for dosage? Absolutely. So a really simple way that I work, if we have someone that has very, very high levels of pain, how do we manage that dosage? How do we manage that intensity, that exertion, to be able, hopefully, to not flare up the problem in the beginning? And then as we move on, we're able to stimulate the system just to edge it back, hopefully, towards being a little bit less sensitized. And as we can see there, we go, 2, 2 and 8, 5 and 5, and then hopefully maybe as that pain sensitivity drops away, as that irritability becomes less, we can start to ramp up a bit of that effort and have those real kind of movement experiences that prove to people that they are strong, they're robust, and they're ready to get back to their valued activities.
Thank you, Ben, so much for your presentation. So I will go with the question. So of course, you can ask if you have some trouble with the English. I can do the translation if you want to ask your question in French, and I will ask to Ben the question in English for sure. We'll go with Alan.
Hello. Thank you so much for that presentation. I thought it was fantastic, and it really made it very practical. My question will, to use your phrase, I'll try to make it not philosophical, but very practical. So I'm a physician, I work in a pain center, and I work with groups of patients. Part of the work that I do is helping them through mindfulness, learn a lot of the stuff you talked about earlier, their emotions, their relationship to movement. We do movement meditation, elements of pain reprocessing therapy.
Yep.
My sense, though, and my sense from the medical community and perhaps patients is, and I want to know if maybe it's different in the UK, but that's not the first line approach in most people's minds, right? They'll still be looking for the pain generator, and when nothing else works, then maybe they'll think about going towards that kind of approach. So it sounds to me from my experience and from the way you're presenting it that maybe we're really bringing this in far too late and really should be right off the bat, but I just want to get a sense of how it plays out in your context.
Look, I mean, that was the point of the biopsychosocial model to some degree, was to start to move away from the biomedical model that looked at, as you described, finding the pain generator. Let's find it on a scan, these type of things. If we go back to people like Norton Hadler and his approach and understanding kind of back pain as a societal problem or even a problem of misinformation. So absolutely, I mean, I think that fundamentally, we from probably kids, we don't have a good appreciation of a modern perspective of pain. It's very much an injury or damage equals the pain that we have. And back pain has been monetized. Medicalization is monetization to some degree. So absolutely, I would say that we need change at a societal level, and that's a bit above my pay grade, unfortunately. So I think that society's perception of pain and medicine do need to change, but is that likely to change in a system that's driven in that way? And that's the tough bit, and that's why things like Engel and Peabody and all these, and Lucer and all these other great people, they're still dissenting voices, aren't they? Even 30, 40 years later, their wonderful words are not made a dent in the wonderful world of medicine.
Thanks.
Thank you. Do we have other questions? Maybe I have one. How do you think you can increase self-efficacy for treatment?
That's a great question. Now, one of the biggest things that I think limits pain self-efficacy changing is our idea that pain always has to go away. So the idea of pain, so if you look at the pain self-efficacy questionnaire, it says, I can do things despite pain. I can work despite pain. Now, if every time that we experience pain, we run to the doctor, or the doctor or the physio or whoever takes that pain away, or every time we do an exercise and it hurts, we say stop. Fundamentally, I think we're eroding our pain self-efficacy, which is great for business, but not always good for people's recovery, because we know it's quite a strong prognostic factor. So I think sometimes we have to re-engineer, and it goes back to Alan's question, doesn't it? Sometimes I think we have to re-engineer people's perception of pain to some degree, which doesn't just happen individually. It has to happen at a wider, broader perspective. We have to have all of the stakeholders working together for that, and and approaching it from a systems perspective, which was exactly what Engel proposed with the BPS model. It was a systems-based approach. It had society, it had hierarchy, it had biosphere. He was getting almost intergalactic with this stuff, right? So I think that we can't always simply change it at a very, very localized level. It has to be at a bit of a broader level. But in the meantime, I think if we tell people every time it hurts to stop or change the exercise or do something different, what are we saying about pain? We're actually eroding pain self-efficacy. So sometimes people have to experience that it hurts, but it hasn't created a bigger problem, that they're not more injured or they're not more damaged. It's just a sensitization. So how do we increase pain self-efficacy? Don't take pain away. Sit with it, be with it, talk about it, experience it. And hopefully that's cognitive restructuring, or maybe it's expectancy violation, or many of these different things.
Thank you for your question, your answer, sorry. I think that your talk was very interesting. We have a lot of great comments in the chat. So I think it's 1 p.m. So people are gonna go back to work, I think. So I think I'm gonna just stop the webinar here. Just quick thing before we go. N'hésitez pas à nous suivre sur nos réseaux sociaux, donc Twitter, Facebook, donc SQD Douleur sur Facebook et Twitter. Aussi, quelques informations à venir. Notre prochain congrès annuel va être le 8 novembre à l'amphithéâtre Pierre Pellado au CHUM. Et si jamais vous avez aimé les webinaires comme celui de Ben Cormack, on va en avoir d'autres dans les prochaines, pour l'année 2024, bien entendu. Sinon, merci d'avoir été présent. Puis l'enregistrement va être disponible. Thank you again, Ben, for your presentation. It was very interesting, and we hope that we can heard about a lot of your works on Twitter, I think, so we can follow you at Core Kinetic on Twitter and also on Facebook, I think, right?
Yeah, and Instagram. I'm not hard to find.
Okay, perfect. With Core Kinetic, we will find you, of course. Thank you so much, everyone.
Right.
Merci
so
beaucoup.
Goodbye.
Bye-bye. Thank you, Ben, for your presentation. It was very cool.
Yeah, I've done a lot of presentations.
You were very comfortable, and the thing is that everyone, I feel that when I talk with a lot of healthcare providers, some people doesn't know those concepts, but it's so much important, and the fact that we need to teach those concepts to our patients to be able to maybe understand more their condition and understand more their chronic pain. So it's very interesting.
Yeah, absolutely. Thank you so much for inviting me.
Yeah, so I think that for the next step, Andrian should get in touch with you for the bill and everything, right? Did she?
Yeah, fine. Yes, I think I sent an invoice.
Okay, perfect. So I will make sure that it's taken charge.
All right. Thank you so much.
Thank you.
See
Bye-bye.
you.
Bye-bye.